Good morning, everyone. I'm Kaoutar Makhlouf, an embryologist at Boudra Fertility Center, Fez, and a PhD researcher at the Intelligent Automation and Biomed Genomics Laboratory, Faculty of Sciences and Technology, Tangier, Morocco. Today, I'm delighted to present my research on impact of clinical and biological factors on intra-cytoplasmic sperm injection, ICSI, success rates, a retrospective analysis of 478 infertile couples. Infertility affects a significant number of couples globally, and ICSI is a key-assisted reproductive technology for treating both male and female infertility. This retrospective study analyzed the clinical and biological factors that influence ICSI outcomes. The primary goal is to assess their impact on ongoing pregnancy rates and explore the causes of infertility in our patient population to optimize treatment protocols and improve ICSI success rates. This retrospective study, conducted at the Boudra Fertility Center in Fez, Morocco, analyzed 711 ICSI cycles from 478 infertile couples between January 2018 and October 2024. Women aged 18 to 45 were included. Data was collected from medical records. A standardized protocol was followed for ovarian stimulation, ovulation triggering, oocyte retrieval, and embryo transfer tailored to embryo quality. The majority of patients were aged 18 to 34 years, 54.18%, followed by 24-27% in the 35 to 39 age group and 21.55% aged 40 to 45 years old. The most common procedures among female patients were polypectomy 9.21%, cystectomy 4.39%, and salpingectomy 4.81%, with less frequent procedures including myomectomy 3.97%. Male factor infertility is the most common cause, followed by female, mixed, and idiopathic factor infertility. The primary causes of female infertility in our study were uterine issues, 42.22%, followed by polycystic ovary syndrome, 30%, tubal disorders, 21.67%, and endometriosis, 3.33%. Regarding male infertility, astenosospermia and oligoastenoteratosospermia accounted for nearly 60% of cases. Azoospermia was present in 21%, while oligospermia, teratospermia, and necrospermia were less common. Nearly half of the couples in the study have been experiencing infertility for 5 years or less. A significant portion, 32%, has been infertile for 6 to 10 years, while 19% have faced infertility for 11 years or more. In our study, the short antagonist protocol was used in 90%. The long agonist protocol was used in 10% of cycles. The average duration of ovarian stimulation in our study was 8.27 days for the short protocol. Ovarian stimulation is monitored by ultrasound on 96%, or estradiol levels on 4%, with checks starting on day 6 and repeating every 2 days until the trigger. Ovulation trigger in ICSI uses HCG, human chorionic gonadotropin, to induce final oocyte maturation before retrieval. Oocyte retrieval occurs 36 hours after the trigger via transvaginal ultrasound under anesthesia. Fruits are examined at 10 to 40 times magnification on a 37 degrees Celsius heated stage to preserve oocyte quality. Sperm is collected on retrieval day via ejaculation after 3 to 4 days of abstinence. In some cases, testicular biopsy or frozen sperm are used. Samples are processed and selected for ICSI based on motility and morphology. Key factors that impact treatment success are biological characteristics of the cycles. In 711 ICSI cycles, an average of 5 oocytes were collected per cycle with 3 mature. Fertilization rate was 60.80%, yielding 1.82 embryos per cycle with 1.13 transferred. Most oocytes were of a good quality, 65%, followed by moderate quality, 25.24%, and poor quality, 9.77%. A large proportion of oocytes were viable for fertilization, a key factor contributing to the success of ICSI. At day 3, 58.07% of embryos were of high quality A, 29.64% were of average quality B, and 12.29% were of poor quality C. Most embryos had a high quality. The majority of day 5 blastocysts were of high quality, 57.51%, followed by good quality blastocysts, 29.53%. A smaller proportion were classified as low quality. This suggests that most embryos had strong development potential, which could positively influence the chances of successful implantation and pregnancy. Regarding the results of ICSI treatment in our study, we found 31.65% of cycles resulted in a clinical pregnancy. Of these, 29.967 led to a live. The multiple pregnancy rate was 5.06% and the miscarriage rate was 0.84%. These results demonstrate a good success rate for ICSI with a low multiple pregnancy rate and a very low miscarriage incidence. Patients aged 18 to 34 account for 80% of the clinical pregnancies with 180 pregnancies. This highlights the significant impact of age on clinical pregnancy outcomes, with notably higher rates among younger patients. Regarding embryo quality, we found quality A, 76% of clinical pregnancies, quality B, 20%, and quality C, 4%. This shows that the majority of clinical pregnancies results from high-quality A embryos. These results confirm that age significantly impacts ICSI success, as oocyte quality and ovarian reserve decline after the age of 35 years old. Baileyburn and al. 2012 and Sankora and al. 2011 also found a sharp decline in pregnancy rates after 35 years old, worsening after 40, supporting this study. Male infertility, the leading cause in this study, reflects the rising impact of sperm disorders like astenospermia and oligospermia on conception. Thomas and al. 2013 found male infertility more common than female infertility. Idiopathic cases remain challenging due to unknown causes. Oocyte and embryo quality are crucial for ICSI success. A 65% good quality oocyte rate is promising, as high-grade embryos at D3 and D5 improve pregnancy outcomes. Research by Miziger and al. 2012 also found the embryo quality is a crucial predictor of ICSI cycle success. High-quality embryos at day 5 generally have a higher success rate compared to those transferred at day 2 or day 3. Good clinical pregnancy and live birth rates with a low miscarriage rate, 0.84%, confirm ICSI's effectiveness, especially for male infertility. These findings align with Gisler and al. 28, who reported about 30% clinical pregnancy rates for ICSI, matching international live birth and multiple pregnancy rates. This study highlights key factors influencing ICSI success, including patient age, infertility cause, oocyte and embryo quality, and infertility duration. Results consistent with international studies demonstrating ICSI's effectiveness, particularly in cases of male infertility. Importance of tailoring treatments to each couple's specific characteristics to maximize success rates. Clinical implications highlight the need for personalized treatment protocols and careful monitoring for each patient. And thank you for your attention.